Hello everyone, in this video we're going to be looking at the Pharynx and Larynx section of the course pack. This resource is brought to you by Scrubs, student collaborative resources for understanding and Brody success. My name is Bryce Pugh, I'm in the class of 2027, and before we get started, let's quickly go through the Scrubs mission statement. Scrubs is a student-driven initiative that aims to develop supplemental resources for current and future cohorts that will pass through Brody. Members of Scrubs participate in a variety of subcommittees working to create resources for students by students. These resources aim to offer a unique perspective from students that have walked in the same shoes, developing resources that we wish we'd been exposed to during our time in the course. The hope is this organization will become a staple of the Brody student body, exemplifying the unique collaborative community that Brody offers. If this is a mission that aligns with your goals and you have the desire to help those that will come behind you, as well as a goal to leave your mark on Brody as a whole, we invite you to join the team. A quick disclaimer. The resources that are included in this document, this PowerPoint, are made by students and not the faculty. As such, there's a possibility for errors in our development, although this is mitigated via a team approach to development with multiple stages of vetting. If there's a contradiction within the coursework presented within your course, please go by the course documents or the course pack. Additionally, Scrubs aims to supply supplemental resources. However, these are in no way a replacement to the instruction of the Brody faculty. Use these resources as a supplement, but not as your primary source for course material. And so let's start with an overview. So first we'll just look at a couple osteology points that you'll need to know going through here. So first is going to be the hyoid bone. So you should have seen this a little bit in lab already, but the hyoid bone is going to be the C-shaped bone right here in your upper neck. And you can see it's going to have a greater horn that's going to go back posteriorly and a lesser horn that's going to run superiorly. And so that's actually going to be just a free acting bone. It's not really connected to any other bones, but it is going to be connected via some ligaments and tendons to our larynx here. And so the hyoid bone, we also have the mastoid and styloid processes. So we should have seen these. I just want to do a reminder. Our mastoid process is going to be up here. You can feel that behind your ear if you rub that hard bone behind your ear. And then we also have our styloid process. So that's going to be the column-shaped bone right here. And these are both part of your temporal bone. Next, let's do a quick recap on fascia of the neck, because these are going to run down through the neck. And so anterior to the pharynx and larynx, which are going to be right here, kind of in your throat region, we're going to have the investing layer, which remember was the really superficial green layer here. And then we're also going to have the pretracheal layer, which is going to be the purple layer here. And so that's going to be pre to your trachea, before your trachea, running down your neck. Posterior to the pharynx larynx, so back here, but before you hit the spine, you're going to have your pretracheal region, specifically the buccopharyngeal, as well as the prevertebral. And so you can look up here and see that. And so we'll look at these a little bit as we go through, but just remember, like, the prevertebral is going to line the vertebrae, and then we're going to have buccopharyngeal, and then on the front we're going to have some pretracheal and investing. Another key topic to remember as we go through here is tonsils. And so we'll see some different tonsils as we look through the pharynx, but what tonsils are is a collection of lymphatic tissue in the pharynx. And so as lymphatic tissue, they're usually the first line of defense as pathogens are going to enter through our nasal and oral cavities. And so you should maybe have seen in histo this topic of MALT, mucosa-associated lymphoid tissue. And so that's what these are. They're going to be a lymphoid tissue that's kind of just inside the mucosa of areas like this. And so in the pharynx, which we'll look at what the pharynx is in a second, but in the pharynx, which is going to be in this region of your neck, we're going to have four. And that's going to be the pharyngeal tonsils, the tubal tonsils, the palatine, and the lingual. And so they're kind of named for where they're at, so you should be able to have an idea based on that. But the pharyngeal is going to be at the supero-posterior aspect of the nasopharynx, so that's going to be up here. The tubal tonsil, or tonsils, because this is going to be on both sides, right, is going to be adjacent to the auditory tube. So we have an auditory tube that's going to run up to your ear. So it's going to be kind of adjacent on the folds right here. Third, we have a palatine tube, and that's going to be between two arches, palatoglossal and palatopharyngeal arches, that are going to be back here. And that's usually what people refer to when they talk about tonsils. They're right here, and that used to be a pretty common thing to get removed when you had tonsillitis, so you might remember that when you were younger, but it's not really done too much anymore. And then finally we have the lingual tonsils, which are going to be at the root of the tongue back here. And so first we'll look at the pharynx, and then we'll look at the larynx. So the pharynx is going to be this region at the back of your throat. And so it's a funnel-shaped passage, and it's common to the respiratory and alimentary passage, so breathing and eating. It's going to begin posterior to the nose, so up here, this is our nose, our nasal cavity, so back here, and it's going to descend all the way to the cricoid cartilage, which is going to be right here. At the cricoid cartilage, it's going to divide anteriorly into the larynx, which will run down here and eventually become the trachea to the lungs. And posteriorly, it'll continue as the esophagus, which is going to go down into our stomach. And so before we look too much at the different layers, because you can probably see here that we're divided into a few layers, let's look at the pharyngeal wall muscles. So the pharyngeal wall muscles are going to be located between two layers of fascia. And that's going to be the pharyngobasilar, which is an inner layer that's really strong and fibrous, as well as the buccopharyngeal, which is going to be the outer layer with mostly loose connective tissue. And so this is kind of an overview of a lot of the muscles, and we're going to divide them into three categories. And so it's not quite three layers like we've seen with some other stuff. It's more just three functional categories. And so that's going to be circular, longitudinal, and palatal. So first, let's look at the pharyngeal circular muscles, the circular layer. And so these ones are should be pretty easy to remember the name. They're going to wrap around like a circle, and we're going to have a superior, a middle, and an inferior one. And so these are called the superior, middle, and inferior pharyngeal constrictors. And they're named that because what they're going to do is constrict in kind of a descending order, and that's going to propel food from the oral cavity down the esophagus. And so one will contract, then this second one will contract, and then that'll contract, and the food will get propelled down. They're going to originate at different points at the side of the pharynx. They have some more specific names, but really all we need to know for the class of 2027 at least is that they attach at the midline at the side of the pharynx, and they're going to insert at the midline posterior raphe, which is going to run down here on the back. They're going to be innervated by the vagus nerve, and we'll see that that's going to innervate just about everything that we're looking at here, and we'll talk more about innervations later, but innervated by the vagus, cranial nerve 10, and these kind of form a layer, but it's an incomplete layer. You can see that there's some gaps here, and so important structures are going to be running through these gaps. So we have our first gap here, which is going to be before the base of the skull, our second gap, third gap, and fourth gap. And so we'll look at exactly what all of these are, but keep this in mind as we're learning the different structures. So in the first gap, we're going to have the auditory tube, which is going to go to the ear, and the levator villi palatini, which is kind of an associated muscle with that. In the second gap here, we'll have the stylopharyngeus muscle and the glossopharyngeal nerve. In the third gap, we're going to have the superior laryngeal artery and the internal laryngeal nerve. And then finally in the fourth gap, we'll have the inferior laryngeal vessels and the recurrent laryngeal nerve. And so these are going to be a really important topic to know, what goes through what. And so I'll try and point out some stuff as we go through and learn them, like the stylopharyngeus. Remember, that's going to go through too. But I would come back and watch this point after you finish this video just to make sure you're actually knowing what's going through all of these. Our next layer is going to be the longitudinal layer of muscles. And so all of these muscles are going to end with pharyngeus. And so they're going to have essentially the same action as all of the constrictor muscles. So they're going to help propel food from the oral cavity down to the esophagus. And so we're going to have three. We have the palatopharyngeus, the salpingopharyngeus, and the stylopharyngeus. And so you can see those here. The palatopharyngeus is going to run just like it's named, it's going to originate at the posterior hard and soft palates. So originate at the palates and run down to thyroid cartilage down here. The salpingopharyngeus. Salpingo is a root that's kind of means tube, and so that makes sense. It's going to run from the auditory tube cartilage down to the palatopharyngeus muscle. And so it's just going to go and attach onto this. So you can see it's attaching at the cartilage here, and it just goes down to attach to that muscle. And then finally, we have our stylopharyngeus muscle, and we'll look at this more in a second. But it's going to run from the styloid process, the column or pillar-like bone, go through the second gap, just like I said, and it's going to eventually go down and attach to the thyroid cartilage. And so two thyroid cartilages, except the salpingopharyngeus, that's going to just attach to the palatopharyngeus. And almost everything's innervated by the vagus nerve, but the stylopharyngeus is one of the exceptions. It's going to be innervated by the glossopharyngeal nerve, cranial nerve 9. And just like considering where these are at, so these are going to be located deep to the constrictor muscles, and it's kind of hard to, or it can be easy to get confused, like what deep is when we're bisecting the head and looking inside. But when I say deep, I mean that it's going to be more closer to inside of the pharynx. And so when we have the heads bisected, if you start peeling back the layer of mucosa, you're going to encounter these muscles first. If you move them out of the way, then you're going to encounter the circular muscles on the outside here. Next, let's look at the palatal muscles. And so we're going to have 4 here. We're going to have our 2 of the villi palatini muscles, which are going to be up here around the auditory tube. And so we have a tensor villi palatini, which is tensing. And then we have a levator villi palatini, which will elevate. And so the tensor villi palatini is going to originate at the scaphoid fossa, which is part of the medial pterygoid plate, and the auditory tube cartilage. And so you can see that here, kind of just a small muscle running here. And it's going to insert on the palatine aponeurosis. So that's going to be down here. So aponeurosis, we saw that in the hand as just like a supportive structure. And so we also have one on our palate. So palatine aponeurosis is just this fibrous supportive structure that's going to be here. And so it's going to insert on that. And what it's going to do is going to tighten the soft palate, and it'll open the auditory tubes when swallowing or yawning or something like that. And that kind of makes sense why, like if you're on an airplane or something, if your ears pop, you can yawn. That'll open up your auditory tube, and it'll kind of equalize the pressure in your head, and that'll fix your ears from being popped. We'll come back to the innervation last. Next, we have the levator villi palatini. So the same name, but levator instead of tensor. That's going to be right here, adjacent to it. And it's going to start at the petrous portion of the temporal bone up here. Remember, that's the bone that keeps all the ear structures inside of it. And so it's going to make sense that the petrous portion of the temporal bone has all the ear stuff. We're going to originate from that. And we're also going to originate from the torus tubarius, which we'll look at more in a second. And it's going to come down and insert on the palatine aponeurosis as well. And it's going to insert posterior to the tensor villi palatini. Next, we're going to have the palatoglossus. And so that's going to be right here. And this is going to be one of our tongue muscles that we'll revisit in the nasal and oral cavities. But you can kind of get from the name where it's going to attach. So palate is going to originate from the palatine aponeurosis and insert on the side of the tongue. And so if that muscle contracts, if it pulls, then it's going to elevate the tongue. So palatoglossus, palate to glossus, tongue, and it's going to pull it up. And then finally we have the musculus uvulae, which is going to be right here. And you can get from the name uvulae, it's going to insert on the uvula. And so it's going to originate from the palatine aponeurosis, insert on the uvula, and if that contracts, it's going to pull the uvula superiorly. And so, again, we're going to see vagus innervation to just about everything, except we have one more exception here. So there's 2 overall exceptions. The first one we saw with the stylopharyngeus, the second one we see with the tensor villi palatini. And it's going to be innervated by cranial nerve V3, the mandibular nerve off the trigeminal. And we should remember from the video we learned there was a little branch that goes to the tensor veli palatini. All right, next let's look at the muscles of the styloid process. And this isn't emphasized very well in the course pack, but it's really important to know, especially for the practical and the cadaver lab, so be sure to check it out in the lab. But we're going to have 3 muscles that originate from the styloid process. And so the styloid process, remember, that's going to be the pillar-like bone up here. And so they're all going to have stylo in their name. So we already looked at the stylopharyngeus, but we'll talk about it more. So we have styloglossus, stylopharyngeus, and stylohyoid. And again, before just trying to remember these, think about what can you gather from the name. So the stylohyoid, that makes sense that it'll go from the styloid process to the hyoid bone. We have the stylopharyngeus, which is going to go from the styloid process to essentially to the pharynx. It's going to insert on the thyroid cartilage in the pharynx, the stylopharyngeus. And then above that, we're going to have the styloglossus, which glossus is tongue. So we're going to insert on the side of the tongue. And so the styloglossus is the function, it's going to retract the tongue. And so it inserts on the side of the tongue, comes back here. If you can imagine, if you're pulling up that way, it's going to pull the tongue back and retract it. So if you have your tongue out, it's going to pull it back into your mouth. And it's going to be innervated by the hypoglossal nerve. And we'll go through this picture, which should help you remember all this in just a second. Next, we have the stylopharyngeus, which is going to be innervated by the glossopharyngeal nerve. And it's going to propel food from the oral cavity to the esophagus, just like we talked about. The stylohyoid is going to be innervated by the nerve to the stylohyoid, which you should recall that from the facial nerve chapter, cranial nerve 7. There was a small nerve that goes to the stylohyoid. And then its function is going to be to elevate and retract the hyoid. And so that back here, it's just one of the muscles that kind of stabilizes it. It'll elevate and retract it, because if we're up here, attaching down here, if it pulls, it makes sense that's going to pull the hyoid bone back that way. And so looking at this picture, we're really going to have our 3 muscles and 2 nerves is the key thing that we want to look at. And so we should see we have in a submental triangle, one of the borders was the anterior belly of the digastric right here. It's going to have this common tendon wrap around and run all the way back and go to the posterior belly of the digastric. And so that's not exemplified super well in this picture, but the posterior belly of the digastric is going to be really, really far back. So you, in the cadaver lab, you're probably not going to see the actual muscle belly until you get way deep here. And so if you see muscle belly running with the common tendon, even all the way down here, if you see muscle running with the common tendon of the digastric muscle, then that's going to be the stylohyoid muscle. So remember that the stylohyoid runs from the styloid process to the hyoid, and it's going to run with the common tendon. So if you see a muscle identified here, you want to be thinking stylohyoid. Inferior to that, but it can kind of run like posterior or around this region. Inferior, there's going to be a nerve that's going to run down and go over here towards the chin. And what that is the hypoglossal nerve. And so hypoglossal, that's going to be our motor function of the tongue. So it's going to kind of travel towards the tongue. And so we're going to have our hypoglossal nerve with our posterior belly of our digastric and our stylohyoid muscle. So that's the first section. If we move superiorly, we're going to have 2 muscles and a nerve as well. So we're going to have our stylopharyngeus muscle, which is going to go from styloid to the pharynx, or the thyroid cartilage. And we're going to have our styloglossus muscle. And so styloglossus, that must be going from the styloid to the tongue. And so you can see styloglossus is going to go towards the tongue. The stylopharyngeus is going to go towards the pharynx. So the one that's more inferior, traveling to the pharynx. The one that's more superior will travel to the tongue, because the tongue is going to be, for the most part, higher than the pharynx. And so between those, this should be making a sandwich of another nerve. And what this nerve is the glossopharyngeal, or cranial nerve 9. So we're going to have the glossopharyngeal running between here. And so if you see a nerve here and here, be sure to be able to identify the differences. And so you can think about what's going to innervate what. The styloglossus is going to be innervated by the hypoglossal nerve. And so we can say the styloglossus muscle is hypoglossal, the stylopharyngeus, glossopharyngeal. That's going to be this one down here. Or sorry, that's going to be this one right here. And then stylohyoid is from the nerve to the stylohyoid. So that's the exception. So these two nerves are going to do two of these, except for that exception. One more thing that's not really emphasized in the course pack, but will be important to look at on your cadavers and for the practical, is these two muscles, the longus colli and the longus capitis, as well as recognizing where the sympathetic trunk is in this region. And so when we have the heads bisected and we're looking at this, if this is the view you have the mucosa layer overlaying the muscles, you retract that, you retract the circular layers, and then you're going to have two muscles kind of laying against the wall. And what that's going to be is the longus colli and the longus capitis. And so those are highlighted here. The longus colli is going to be running up here. Or sorry, the longus capitis is up here because we wear a cap on your head. Capitis is going to be higher up. Longus colli is going to be running a lot more down, and it's going to be more medial. So when we're up here, we should be seeing kind of this region. Also, if you are moving the circular layers back and you're looking deep to the circular layers down here, you'll see these two muscles, but you'll also see some nerves. And so if that's retracted, you see a nerve tagged under there, that's almost definitely going to be part of our sympathetic trunk. If you see a ganglion, it's going to be the superior cervical ganglion. But if you just see nerves, that's going to be almost definitely part of our sympathetic trunk. And so now let's look a little more at the pharynx as a whole. And so the pharynx is going to be divided into 3 regions. So this is a really common trend all throughout the body, is dividing things into 3 regions. The pharynx is also going to have 3. We're going to have our nasopharynx, which is going to be purple, posterior to the nose. We're going to have our oropharynx, which is posterior to the oral cavity, so the green one here. And then we're going to have our laryngopharynx, which is going to be posterior to the larynx. So they're all named for the structure that they're posterior to. Before we look at these, I also want to point out the existence of the pharyngeal isthmus, and it's going to separate the nasopharynx and the oropharynx. So we have our nasopharynx, our oropharynx. It's going to be separated up here by the pharyngeal isthmus. And I've highlighted that here. And what it's going to do, it's going to close when you swallow by the soft palate elevating to the posterior wall. So the soft palate, you swallow, the soft palate is going to elevate and your food will go down. And what that's going to do is prevent the retrograde movement of food or drink up into the nasal cavity. And that's also why you can't breathe while swallowing, because that's going to close. And during respiration, so when you're breathing, the soft palate is going to act as a flap valve. So it's going to be open and allow continuity between the naso and oropharynx. So then you will be able to breathe through your nose and through your mouth. And so first we'll look at the nasopharynx. So we're going to be up here, posterior to the nose, but superior to the soft palate. So that's kind of the boundary here, is the back of the soft palate up. And so what it's going to do is open into each nasal cavity. So remember, you're going to have 2. You have 2 nostrils. You can stick your finger in your nose. You got 2 nasal cavities. And so it's going to open into each one via 2 choanae, which are posterior nasal apertures. And so the walls of it are formed by a mucous membrane. So pretty much all of the pharynx we're going to see is formed by mucous membrane walls. And this is going to line the superior pharyngeal constrictor muscle and the levator and tensor villi palatini, which are all going to be up here. There's also a structure called the torus tubarius, which is cartilage extensions up here. And it's part of the auditory tube. So cartilage of the auditory tube is going to form bulges around the auditory tube. And that's the torus tubarius. So you can see that kind of forming around here. Inferior to the torus tubarius, we're going to have the salpingopharyngeal fold. So the torus tubarius is formed kind of superior and lateral to the auditory tube. Inferior, we have the salpingopharyngeal fold. and that you can imagine is going to be formed by the salpingopharyngeal muscle. And so it's just kind of a mucous membrane layer overlaying this muscle, which will create a fold. This is also the location of the pharyngeal tonsils and the tubular tonsils. So the pharyngeal tonsils we talked about are going to be at this upper back section. So you can see that here. And the tubular tonsils are going to be not really pictured here, but kind of just adjacent to the auditory tube. You can see here, we talked about these two muscles, as well as the salpingopharyngeus muscle here, and the superior constrictor is going to run all the way up into this region. Next, let's look at the oropharynx. And so oro, that's going to be behind the oral cavity. So the green section here, it's going to be inferior to the soft palate. So the soft palate was the border on the top, so it's going to be the border here. In this region, we're going to have the palatoglossal arch or fold, which is going to separate it from the oral cavity. It's going to be formed by the palatoglossus muscle. So again, continuing the trend where we have some sort of structure covered with a mucous membrane that's going to form a fold or an arch. So the palatoglossal arch is formed by the palatoglossus muscle. Adjacent to that, we have the palatopharyngeal arch or fold, which is formed by the palatopharyngeal muscle. And that's going to be in here. And those are kind of, I highlighted those here. The palatoglossus arch is going to be wrapped in here, and the palatopharyngeal arch is going to be here. So the pharyngeal one, closer to the pharynx. The glossal one, further anteriorly towards the glossus or the tongue. And so located between those arches, we're going to have a depression, which is going to be the location of our palatine tonsils. So that's our palatine tonsil right there. And then we're also going to have our lingual tonsil found in this region. So the lingual tonsil is just like at the root of the tongue here. Also here, we're going to have the epiglottic valleculae. And what those are, that's in this picture here, are depressions at the base of the tongue. And so you can see these kind of depressions in the back of the tongue here, and that's the epiglottic valleculae. And they're lined by more folds. And so we have a median fold right here and two lateral folds. And those are glossoepiglottic folds because they're folds between the glossus, the tongue, and the epiglottis, which we'll look at a little later on. But we have our epiglottis here, and we have one median, two lateral folds here. Next, we'll move on to the Laryngopharynx. And so this is going to be found posterior to the larynx, which is going to be up here. So this is the yellow region. And it's going to travel from the inlet of the larynx, so right there, to cricoid cartilage. And at the cricoid cartilage, it's going to continue as esophagus. So right here in the yellow region. In this area, we have an important structure, which is the piriform recess. And that's going to be found on each side. I highlighted that here. It's just kind of this spot, and it's actually clinically important because a lot of like food or like if you eat a fish bone or something, it can get stuck here. And so that's clinically important. We'll look at that later, but it's kind of just a pocket that things can get stuck in. And it's located between the aryepiglottic membrane medially and the thyroid cartilage or thyroid membrane laterally. Here we can also see the cricopharyngeus, which is in the inferior portion of the inferior constrictor muscle. So we have our constrictor muscles lining this in the inferior portion of the inferior constrictor muscles, so really far down, we're going to have our cricopharyngeus. And what that's going to do, that's a muscle, it's going to have a sphincter-like function that will relax when swallowing. And we'll revisit that in a second. Before we move on to the larynx, let's look at innervation of the pharynx. So we've kind of seen this already, but let's kind of look at the bigger picture. So for the pharynx, we're primarily receiving innervation from the pharyngeal plexus. And so remember from the glossopharyngeal and vagus nerve video, we have the pharyngeal plexus, which is a bunch of branches that come off. And so this is going to be, just like I said, contributed to by the pharyngeal branches of the vagus and the glossopharyngeal nerves, so 9 and 10. We're also going to be made of sympathetic components, because our sympathetic trunk is going to be running up through here. And so we'll have sympathetic components contributing as well. And so looking at the trends, all muscles, with two exceptions, but other than the two exceptions, all muscles are going to be from branches of the vagus nerve. So if you can't remember, it's always going to be a safe bet to say vagus. The two exceptions are going to be the stylopharyngeus, which we looked at is cranial nerve 9, glossopharyngeal. You can remember that because stylopharyngeus, if you've got style, you're going to be glossy. So glossopharyngeus, stylopharyngeus, or glossopharyngeal. And then our other one is going to be our tensor villi palatini, so V3. We also have sensory innervation, and that's going to be a little more split. So sensory is primarily going to be from the glossopharyngeal, and that's going to go, don't try to remember this, just think back to the glossopharyngeal video, think about what it does, and remember we saw sensory to the posterior 1/3 of the tongue. It's also going to do some sensory to the lateral aspect of the pharynx at the palatoglossal and palatopharyngeal arches, so the two arches that wrap around the palatine tonsil. Sensory innervation will also come from V2, and that's going to be the soft palate and the nasopharynx. We're going to see sensory from cranial nerve 10, the vagus, which is going to be mucosa posterior and inferior to the palatopharyngeal arch. And so that's kind of moving down the pharynx as we look at these. And so this is one topic that's pretty commonly missed on quizzes and exams, is the innervation of all of this pharynx and larynx structures. And so I think it's really important that you know the innervations. Don't try to memorize every single muscle, what goes to it, just memorize the general trend and the exceptions. And as you go through this, try and recall the nerve pathways that we've looked at previously, like the vagus and glossopharyngeal, and consider what functions or sensations would be lost if we saw a lesion. So we'll look at that a little bit in the clinical correlations, but if you saw a lesion right here, what's going to happen? We're going to lose this muscle and stuff like that. And so now we'll move on to the larynx, which is going to be more anterior. So we'll look at exactly what it is, but with the pharynx, we saw it running down to become the esophagus, so it's going to be a little more posterior, these muscles here. The larynx is going to be on the front here, and that's going to lead down into the trachea. And so the larynx can commonly be referred to as the voice box, and it's found between the 4th and 6th cervical vertebrae, so right around this region. And it's going to have two primary functions. The first one is going to be airway integrity. So the larynx has this cartilaginous skeleton, which is going to maintain structure for airflow to pass through. It can also stop airflow by controlling the vocal cords, and we'll look at what the vocal cords are, but it's going to maintain structure for air to pass through, and it can also close the doors or the vocal cords to prevent air from passing through. The larynx is also going to function for voice production, and we'll look at a couple important muscles that do that, but that's where it gets its name, the voice box, and that's going to do things like tone or just voice in general. And so first, let's look at the cartilaginous skeleton. So all the cartilage around here, that's going to be the grayish blue colored stuff. And so the cartilage is attached to the hyoid bone, which is right here, the C-shaped bone in the neck, via the thyrohyoid membrane. That's going to be all this. And that's made up of a median and two lateral ligaments. And so you can see this looks kind of complicated. There's a lot of different pieces, but we're really just going to be made up of 5 major cartilages. And that's going to be the cricoid, the thyroid, the epiglottis, and the arytenoid, which is going to have 2 pieces, so that makes 5. So here's a good picture that's going to highlight each of the different cartilages that we're going to look at. It also includes the corniculate, the purple, which is a minor one that we'll look at, but these are going to be the main ones that we're looking at. And so first we have our epiglottis, which is the green one up here, and it's this leaf-shaped structure, and superiorly up here it's going to be really broad and free, and down here it's going to be more narrow and attached. And so It's laterally enclosed in the aryepiglottic folds, and it's inferiorly connected to thyroid cartilage, which is the red stuff. So it's inferiorly connected here by the thyroepiglottic ligament. So we have a lot of ligaments that are going to connect all of this. So the thyroepiglottic ligament is going to connect the thyroid and epiglottis cartilage. Next, we'll move on to the thyroid cartilage, the red one here, which is composed of two lamina, which are kind of like plates, and that's going to be one on this side, one on that side. They're going to meet at the midline anteriorly, which is right here, and form an angle that's going to go down like that. And in men, that's going to be a lot more prominent and obvious, and that's where the term Adam's apple comes from, because that's going to really stick out in their neck. And then we're going to have the posterior border, so back here, it's going to continue cranially as the superior cornu. Cornu is kind of like a horn, so our superior cornu, and caudally, or inferiorly, as the inferior cornu. Next, we'll look at the cricoid cartilage, which is the yellow here, and it's the shape of a signet ring, which is the ring wraps around and then has like the big flat circle at the top, kind of like a class ring. And so it's going to be the most inferior of the cartilages, and it's going to have a lamina, or like a plate, facing posteriorly. So the ring is anterior. And it's going to have 4 synovial joints that produce facets. And you can kind of see here all of the connections that it's forming. So there's going to be 2 cricoarytenoid joints, which are going to go from cricoid cartilage to arytenoid cartilage, and 2 cricothyroid joints. So from cricoid cartilage to thyroid cartilage. Finally, we'll look at the arytenoid cartilage, which is going to be this 3-sided pyramidal structure, and the apex of each of those is going to curve posteromedially, so medially posterior. The bases are going to articulate on the upper border of the cricoid lamina, so right here you can see that. It's going to attach right there is what that means. And the posterolateral angle, so down in this corner, is called the muscular process, and that'll become important as we look at all the muscles here. But right here's the muscular process, and it's going to attach to the laryngeal muscles. This is also, we have the anterior or vocal process is going to attach the vocal ligaments on here. And then we have a few minor cartilages that are not as important to know, but I would still make sure you know just briefly what they are. And so we have the corniculate, which you can see is outlined here in purple, and it's going to be at the apex of the arytenoid. We have the cuneiform, which is in the aryepiglottic folds, and the triticiole, which is in free posterior edges of the thyrohyoid membrane. And so just like the pharynx, our larynx is going to be divided into 3 regions, and they're going to be separated by some folds. So we have 3 regions. We're going to have a superior vestibular fold and an inferior vestibular fold, which are going to be the landmarks. So our superior vestibular folds are these right here, and that's going to be known as our false vocal cords. And then we have our inferior vestibular folds down here, which are going to be known as our true vocal folds. And that's going to be like this picture you've probably seen when looking at the larynx. This is a pretty common picture. You're going to have your true vocal folds, which are the more white ones here, and our false vocal folds a little more laterally, which are kind of the pinkish color here. And so this has a name: supraglottis, glottis, subglottis. The course pack refers to it a little bit differently, but it's essentially the same thing. So up here in blue is going to be our vestibule, which is the most superior space, and it's going to extend from the laryngeal inlet, which is also known as the adductus, or the opening to the larynx, and it's going to go down into the vestibular folds. So it's going to stop at the superior vestibular fold. Between the 2 vestibular folds, we're going to have the ventricle, which is the small middle portion. And among that, we're going to have this small space between the superior or false vocal cords, and then a small space between the inferior or true vocal cords and the superior one. That's going to be called the rima vestibuli. And between the inferior ones, that's the rima glottidis. Traveling more inferiorly, so once we get inferior to the rima glottidis, we're going to hit the infraglottic or below glottis infraglottic space. And that's going to lead down and eventually become the trachea, which will go to your lungs. A couple important points. The vocal ligaments provide support to the vocal folds here. So we have our vocal folds. Those are going to be supported by vocal ligaments. And both sets of these are going to run antero-posteriorly. So in the plane, they're going to run transverse like this and project inward from the sides of the larynx. And so now we'll look at all the muscles of the larynx, which are going to give it all of its special functions. And so again, we're going to divide into 3 categories, and that's going to be more of a functional category rather than layers or anything like that. And so we have a sphincter, some sphincter muscles, which are going to give us sphincteric function at the adytus, which is the opening, and the vestibule. And what that's going to do is prevent food and water from entering into the larynx, because that's where we're going to breathe. We don't want food and water coming into here. We have our abduction and adduction muscles, which are going to act on the vocal folds to open and close them. And that's going to occur at the rima glottidis. And finally, we have tension muscles, which are going to be provide tension or loosen tension on the vocal folds, and that's going to alter the pitch of our voice. So first we'll look at the sphincter muscles, and they're all going to have the same action and innervation. So we'll look at the laryngeal innervation closer to the end, but we're going to see, again, some more common trends. It's all vagus for the most part, and for the most part also it's going to be inferior laryngeal. All of these are inferior laryngeal nerve. The action for all of these is going to be that sphincteric action, which is going to be preventing food and water from entering into the larynx. And so what we're going to have here, it's going to be found here on the picture. We're going to have our oblique arytenoid, which is going to wrap around this. It's going to wrap around the larynx in kind of an oblique way. That's where it gets the name. And it's going to go up here. Once it gets to about this region, then it's going to change names to the aryepiglottis and continue up. And so you kind of see that here. When we're wrapping around, it's the oblique arytenoid. Once we get to about here, then it's the aryepiglottis. And so the oblique arytenoid attaches at the arytenoid cartilage, which is where it gets its name, and it inserts or kind of continues as the aryepiglottis muscle. And so that's going to be the origin of the aryepiglottis is the oblique arytenoid, and it's going to continue and attach at the aryepiglottic fold. The thyroepiglottis is another one we have here that can't really be seen in this picture, but it's going to be these really thin muscle fibers right here that are kind of traveling in the opposite oblique way. And it's going to originate at thyroid cartilage lamina and insert on the epiglottis up here. And that one is thought to have kind of a secondary side function, which is going to pull and depress the epiglottis when swallowing. Next, we'll look at the abduction and adduction muscles. And so, again, we'll see inferior laryngeal is going to innervate all of these. And so we have the same innervation, and they're all pretty much going to insert on arytenoid cartilage. And so first we'll have the posterior cricoarytenoid. And this one is going to be really, really important because it's the only abductor of the vocal folds. So if you know any of these, make sure you know the posterior cricoarytenoid, because without that, we wouldn't be able to abduct the vocal folds. We wouldn't be able to breathe. We wouldn't be able to open our pathway towards our trachea. So posterior cricoarytenoid. And so that's going to originate at the cricoid lamina, insert on the arytenoid. So you can imagine cricoarytenoid, that's got to be its attachment. So it's cricoarytenoid. And then posterior is just describing it. We're also going to have a lateral cricoarytenoid, which, again, cricoid cartilage, arytenoid cartilage, that's where it gets its name. And it's going to adduct the vocal folds. So we'll look at the vocal folds, but it's going to kind of bring them to midline, which is going to narrow or close the rima glottidis. And then we have our transverse arytenoid. So that's going to originate at arytenoid cartilage and insert on the arytenoid cartilage of the other side. And this is also going to adduct the vocal folds. So we have a couple adductors, but there's only one single muscle that abducts the vocal folds. So this is a really important one. Those are highlighted here. We have our arytenoid, the transverse arytenoid, which is up here. And then the cricoarytenoids, we have our lateral and posterior. Next, we'll look at the tension muscles. And so the tension muscles, we talked about, they're going to tense up or release tension to change the pitch of your voice or the tone of your voice. And so we're going to see the continuing trend of inferior laryngeal, of cranial nerve 10, innervating everything, except we now see one exception, which is the cricothyroid. And this is the only muscular nerve exception because it's going to be innervated by the external branch of the superior laryngeal nerve, which is coming off the cranial nerve. And so first we have our cricothyroid. And so that is going to make your voice really high. It's going to increase tension of the true vocal folds, of the true vocal ligaments, and raise the pitch of your voice. So anytime you see cricothyroid, I want you to say cricothyroid. Next we have our thyroarytenoid, which is going to decrease tension of your two vocal ligaments and deepen the pitch of your voice. So every time you see that, say thyroarytenoid. And then finally, we have our vocalis, which is going to adjust the vocal cords for speaking and singing. So that's going to kind of generally adjust your tune and stuff like that. And so the vocalis is actually the innermost fibers of the thyroarytenoid. So over here, we can see our cricothyroid over here, and our thyroarytenoid. And so the innermost fibers are our vocalis. And so here's another view just kind of re-emphasizing what all of these functions are. So here we have our rima glottidis and our vocal folds. And so first we'll look at the lateral view of the cricothyroid. And so that's going to pull down, that's going to increase tension on this, and that's going to raise the pitch of your voice because you can see it's going to pull it forward. Next, this is a superior view of the posterior cricoarytenoid. Make sure you don't forget that one. That's going to be the only abductor. So you can see that's going to pull this way and open up our vocal folds, which will allow passageway into our airway. And that's another view of it. Next, a superior view of our transverse arytenoid right here. And so that's going to pull together, and that's going to adduct towards the midline. So that's going to help close or narrow the passageway. Next, this is a superior view of our thyroarytenoid. And so that's going to overlay here, kind of like that. And that's going to kind of decrease tension, and that's going to make your voice deeper. And you can see the vocalis muscles are the really innermost fibers of that. And so that's your vocalis. Next, we have a superior view of our lateral cricoarytenoid. And that's going to be right here. And you can see that's going to pull up from the base, and that's also going to adduct towards the midline to close or narrow the pathway. And then finally, this is a view of our oblique arytenoid, which remember was one of the sphincter muscles. So you can see it's kind of wrapping around here. And so if that contracts, that's going to squeeze it together and close the passageway. And so there's another view of that. So now let's look at innervation. We've seen pretty much all of it has been about the same thing, but a couple exceptions. So let's look at the general trends. And so the superior and inferior laryngeal branches of the vagus are going to innervate all of the larynx. And so we have our superior laryngeal and our inferior laryngeal. If you remember back to the vagus nerve video, we're going to have the superior laryngeal come off and bifurcate into the internal branch and the external branch. The external branch is going to go to the cricothyroid. So the external branch of our superior laryngeal muscle goes to the cricothyroid. The internal branch is going to do sensory innervation to laryngeal mucosa superior to the true vocal folds. So above the true vocal folds, we're internal superior laryngeal. And that's going to be this stuff here. And then our inferior laryngeal is, remember, that's the continuation of the recurrent laryngeal. So our vagus is going to come down, give off a recurrent laryngeal. On the left side, it's going to wrap around the loop of the aorta, the arch of the aorta, and travel back up. On the right side, it's going to wrap around the subclavian. Make sure you see that in lab too. Make sure you look at it on your cadaver because it's really common to get tagged. It's almost definitely going to get tagged. You can't see it on the left side because we haven't gone down into the thorax yet. But on the right side, you should be able to see the recurrent laryngeal wrapping around the right subclavian. So make sure you find that. And so we're going to be the recurrent laryngeal, keep traveling up, and eventually become the inferior laryngeal nerve. And so what that's going to provide is sensory innervation to laryngeal mucosa inferior to the true vocal folds. And so motor, it's going to also do motor innervation to the remaining intrinsic laryngeal muscles. And so if you have, again, with nerves, we always want to be thinking about lesions. What function are we going to lose? What sensation are we going to lose? And so if we get a lesion on just the external branch, that's only going to lose our cricothyroid. But if we get one on our inferior laryngeal, that's going to go to essentially every muscle except for that. So we're going to lose basically everything in our larynx. Next, let's look at vasculature. And so this is going to be vasculature of the pharynx and larynx because thankfully it's pretty simple. So our pharynx is going to be just receive vasculature supply from the external carotid, branches of that. And so again, with vasculature, remember we don't usually want to be thinking about a specific structure or muscle that's receiving blood from a certain vessel. We want to be thinking more regional. So it's going to be generally a little more regional. You don't need to know specific stuff, but off our external carotid, we're going to have our ascending pharyngeal branch. So it has pharynx in the name. Our ascending pharyngeal branch is primarily going to do all the vasculature of the pharynx. It's going to be supplemented a little bit by the facial and maxillary arteries. So I highlighted those here, our ascending pharyngeal, our facial and maxillary. Our larynx, we have laryngeal branches of the superior and inferior thyroid arteries. And so I marked this here. And if you, like the superior laryngeal artery, if we go up here, you follow that back, that's a branch or a continuation of the superior thyroid artery. So we have our inferior thyroid is going to go and give off the inferior laryngeal. Our superior thyroid is going to go and give off the superior laryngeal. And so those laryngeal branches are going to be all the vasculature of the larynx. And they're going to accompany the internal and inferior laryngeal nerves. Next, let's look at lymphatics of the pharynx and larynx. And so again, not too much to look at here, but a couple important factors to remember. With our pharynx, lymph is going to drain into the retropharyngeal and deep cervical nodes. And I put a picture here just to kind of outline all the lymph nodes that we have here, with this being an anterior view of our larynx, and our pharynx would be behind that. Got our thyroid gland here and some veins, because remember, lymph nodes tend to travel with veins. So retropharyngeal, deep cervical is the pharynx. Our larynx, superior to the true vocal folds, so higher up, we're going to flow cranially towards the cranium, towards the head, to superior deep cervical nodes. Inferior to the true vocal folds, we're going to flow caudally or inferiorly towards the inferior deep cervical nodes. So with all of these, we're seeing deep cervical nodes. The larynx is going to, upper part will go superior, lower part will go inferior. Pharynx will just go in general to all the deep ones, as well as retropharyngeal. And so to end the video, let's look at some clinical correlations. And so there's a lot of clinical correlations, but they're smaller ones, so there's no like really, really big ones. So the stimulation of the soft palate, so if you stimulate the soft palate or the posterior pharyngeal wall, you can achieve a gag reflex. But this is not just specific for the glossopharyngeal. And so parasympathetic components of glossopharyngeal can be tested by observing parotid secretion levels near the upper second molar. Moving on, indirect laryngoscopy is a technique used to inspect hidden areas of the pharynx or larynx. And so that can be used to visualize a lot of different regions that are kind of hard to see using just a little mirror on a stick, essentially. Next, an enlarged pharyngeal tonsil. So we have a lot of pharyngeal tonsils. If any of those get enlarged, those are called adenoids. And this can compromise passage between the naso and oropharynx, which will block off this pathway and force someone to breathe out of their mouth. We can also get enlarged tubular tonsils up here near the auditory tube, and if that gets bad enough, then that's going to close the pharyngeal opening of the auditory tube. We can also get bacteria infection. We talked about that's why we have the tonsils, is to filter out so much stuff that we're breathing and smelling that's going through all of this. But if we get an infection here, two things can happen. One, it can cause swelling of the epiglottis or vestibular fold, and that can necessitate a life-saving tracheostomy. Or it can also pass through the pharynx into the retropharyngeal space, where that's behind the pharynx, before we get to the prevertebral fascia. And so it can enter this retropharyngeal space and spread down into the thorax. Next, disease or surgery can compromise the superior or recurrent laryngeal nerves. So we looked at the superior and recurrent laryngeal nerves. These are really, really important for the larynx. So if you're doing surgery, you definitely do not want to nick those, because that's going to wipe out all laryngeal function. And so if that happens, then that can impair or abolish like the cough reflex. Remember, we have the nerves on both sides. So if you nick one, then that's going to affect one side. And so the vocal fold on the affected side, the one that got nicked or messed up by disease, then that will be unable to be tensed. If you get damage to the nerve, then that will paralyze intrinsic muscles on all of the intrinsic muscles on that side. And therefore, when doing a surgery in this region, before they do any like cutting or going too far, they're going to identify these nerves and kind of make sure they have them, put them to the side, and then continue on with whatever they need to do. So our vocal cords, if one of them gets paralyzed, then regular coughing is going to be impossible. You're going to have messed up, weird coughing. If both of them get paralyzed, or the larynx has been removed, then coughing will be impossible. Next, the piriform recess. So we talked about that as being sort of a pocket. It's a really common location to get foreign bodies like food or like fish bones, if you eat fish, to get stuck, and that can cause pain and irritation, and that'll give a sensation like you have something stuck in your throat. And then finally, there's a procedure called a cricothyrotomy, and that's done in an emergency case where air can't pass through the larynx. So if air can't pass through here, then a median cricothyroid ligament, which is right here, will be perforated at the midline to establish an airway. So if you can't get air through here, they're going to puncture this and go through to give you air.